you're structuralist as well. You do structural work, correct?
Yeah, I do TAVR as well. Yeah.
Are there any role for radial to peripheral in the structural world?
Oh, I love it. Yeah, Sam, this is actually another really nice benefit is when you have, and this actually happened recently, and you'll see this hopefully not too often, but you have a patient who had a recent femoral procedure, likely large bore, even hemodynamic support, where there's an issue, whether it's bleeding, whether it's a decreased flow, claudication after the procedure, a plug that plugged the hole too good. So we see that quite a bit. And so radial to peripheral is a great technique to get those treated well. I've used it, so I'll say one is post large bore access for valvular cases where there's been a groin issue. Great technique, because especially if the groin's been accessed within the last week or two, I really don't want to stick that same groin, especially if there's ecchymosis, hematoma, a lot of different things in that and really not knowing kind of what's been going on. You don't want to stick that side. Some of these cases, if you're using bilateral groins, such as transcatheter valves, both of them have been stuck. Sometimes with a plug that you really don't want to hit, then you're going above or below. So the radial, really R2P in those cases is excellent. Another strategy I've used in patients that are larger, severe obesity that have, for instance, an Impella catheter. So if you want to employ dry closure, I do that all the time, where we will place take the Impella out, and I'll have a dry closure technique from a balloon from the radial. And then I'll be able to inflate the balloon, make sure we have time to really fix the groin, especially in shock where you don't have pre-close or per-close already deployed. It's a nice access point where you don't have to, again, hit another femoral artery and then deal with closing that femoral artery. So it's another technique, but I've been using radial to peripheral in those cases many times. And I think that's a nice utilization for what we do.
Shay, I'd love to pick your brain on equipment, technical stuff. We have probably 15 more minutes. So what should people have on their shelf from a microcatheter length standpoint, wire length, and obviously balloons, stents? And we know that thrombectomy and atherectomy is a little impediment, but I'm sure Sam can give us his long experience with laser and CSI, etc.
Yeah, absolutely. I mean, I think just before I talk about what you should have, one of the limitations that I've been pretty vocal about is imaging. I think, anything proximal SFA and below from the radial approach is very tough to do intravascular imaging. OCT, we still don't have that, in which I'd really love, because I do image everything I can, especially in the coronary and the periphery if possible. So imaging still is a problem, but we do now have wires that are 400 length. Obviously, we used to use the Viper wire a lot because that was a long wire. And even if we didn't do CSI, we would use it if we had to do, especially monorail things. But now we have a lot of options in the RX. So there's balloons, there's stents, there's DCB. You can do IVL into a 150 shaft. There are some specialty balloons, cutting balloon technology that goes to 150. You do have the ability to do laser atherectomy as well as orbital atherectomy on these longer segments. But I think, 400 millimeter length wire is very helpful, as well as having, the longer shaft balloons in DCBs. And obviously the R2P sheath goes from the 75 centimeter to all the way down up to 149 centimeter length. And then from there, you're able to use those to kind of rail your equipment. But I think the game changer has been the addition of balloons and DCBs on longer shaft. And I'm sure there's more to come, but I think DCB on a longer shaft was very helpful.
And Sam, from your experience between laser atherectomy and orbital atherectomy, which are available in 200 centimeter shafts, do you feel like there's any other lesion subsets you cannot do from the radial?
I think the two subsets that I would say away from in the radial is thrombus. even with the laser atherectomy, I think we're more comfortable doing thrombectomy. The largest laser we have is a 1.5 XL from Arion. Yes, it's indicated for thrombus, but I did last week actually, an LVAD patient, previous, PT stent that thrombosed. I was very comfortable putting a laser there, deliver energy, balloon it, looked great. But if I'm having like a fempop bypass occlusion with thrombus, if I'm having, stuff like that, I'll stay away from that. The second thing, when you want to use an bioabsorbable scaffold below the knee, you definitely need either antegrade axis or up and over or pedal, just because of the shaft length. The laser atherectomy really made a significant improvement of what things we can do. I used to not liking to treat instant restenosis via radial for two reasons. One, I didn't have any true atherectomy. I can use a CSI or orbital atherectomy. The laser changed that because that's one of the indication. And to the DCB, till recently, we didn't have any DCB that's 200 shaft, and Medtronic came with their over-the-wire 200 3 years ago. And now we have a Ranger from Boston, which is a rapid exchange. Things are changing. I think the challenge is that each company working separately. They're not communicating. They're like, you get a company who does the atherectomy, but they don't do the microcatheter. Then the company who does the microcatheter, but they don't make the wire. And when they make the wire, they don't ask people what characteristic of the wire we have. So right now we have Glide Wireless 400, that's 035. We have the F18 018. That's a company that Medtronic bought recently, so it's a Medtronic now. There's an 018, and you have the Viper, my favorite wire of all time. Actually, I don't like it at all. I'm joking.
Yeah.
But it's a 475. My staff always joke like they're gonna work on the other room. But I think in general, again, do you have to do complex cases? But a case when I have an LVAD on anticoagulation with an INR of 3.1 that needs it, I've done below the knee cases with laser and balloon angioplasty, things like that. Absolutely, it's not for all cases. But honestly, pedal is not for all cases, and groin is not for all cases. You definitely need to be selective.
Yeah, so as Sam was saying, actually, we do have a microcatheter through with Terumo. They have the Navicross 200, which is a nice utilization of that. I've used that quite a bit. I like the Navicross subsets, which I use. They have the different platforms, so I use that. And now I do have the F14 and F18 wires that are longer through Medtronic, through the Japanese company. So there are some options, but the microcatheter now being at 200 is really helpful for those in the SFA popliteal lesions that are still tortuous and tough to navigate. It also gives you the ability to, as you know, take some pictures and reset, take a different wire, change if you need to do atherectomy. As we said, I used to use the Viper wire for everything. That's always kind of not a great wire to work over if you're not doing orbital atherectomy, but that's obvious. But I think now with these wires, you're able to use a lot and remember some of the things that you need. The other thing to remember is that depending on what you're using, it utilizes a different size. So for instance, Shockwave 014, if you wanted to IVUS something proximal and you had an 014 or 018, then you have to understand your size matrix and to the devices and things you're using. And so sometimes it's nice to have the microcatheter, be able to exchange out, and then know what you're getting into, and then base your wire based on that so that you're not switching your wires out a lot just for the purposes of getting to different devices.